we're glad everybody's here. So I'm pleased to introduce Dr. Thelma. Is it Mielenz? Is that how you say your name, Thelma?
Mielenz.
Mielenz.
Yep.
Who is on the faculty of the Mailman School of Public Health, and she's assistant professor at Columbia. And even though my office is right across the street, I've not met her before, but I'm also very interested in psychometrics and measurements. So I'm happy. I'm really looking forward to hearing her talk. Thelma is the director of the Education Core under the Columbia University Center for Injury, Epidemiology, and Prevention, which is funded by the Centers for Disease Control. And she's the principal investigator of a foundation project translating the CDC fall prevention clinical toolkit for use in public health settings, and a behavioral change project from PCORI, a behavior change translational falls project. I've never heard this title before, and because I'm on more the mental health side, but Dr. Mielenz is a behavioral consequential epidemiologist, which is a title I love. And her research is focused on redesigning healthcare to deliver preventative services, forming clinical and community linkages, creating community and evidence-based programs to prevent disability and falls, and promote self-management of pain. And importantly for this, the psychometrics of outcome instruments to measure pain, function, and physical activity. She completed her doctoral training in epidemiology at the University of North Carolina, wonderful program, where she also received her BA. She also got a master's degree at Mass General Hospital Institute of Health Professions. And I believe you've done something in physical therapy as well.
Right.
Because I'm stalking her these days. I'm stalking her, looking her up. But in any event, she's going to, which is something I'm really looking forward to, is to give an overview of health measures that can be used in injury research. So welcome, Dr. Mielenz, and we're looking forward to your talk.
Yeah, thank you so much, Prudence, for that kind introduction. I appreciate it. So I'm going to go ahead and share my screen here. Okay. Can everyone see the slides fine? Okay. Let's see. And actually, it looks like, let me just. Okay, I don't know why it's doing this. It's starting at the end, but I'm going to go. Okay, there we go. Am I still on Zoom?
You're on Zoom, but we don't see your slides.
Okay, I'm still on Zoom. Sorry. One more time here. Could you see my slides when I shared it?
Yes.
Okay. Sorry, I lost Zoom in the screen. Here we go. Okay, here, and we're off here. Okay, so I'm going to talk about health and function measures around injury that can be used in injury research. So
we can't see the slides right now.
Huh. I wonder.
You're probably using two screens, right? That's where mine always messes
Yeah,
up.
I'll try it one more time here. Okay, share. Can you see the slide now?
Yes.
Okay. Okay, hopefully we're off now. Okay, good. This is, okay, all set. So the focus of injury severity measures is really to address the threat to life of a subject, and it ignores the non-fatal injury and the long-term disability that may arise from this injury. So disability is measured by functional outcomes, and when I mean functional outcomes, I'm referring to mental, physical, and social outcomes. So this is the alphabet soup of injury severity measures. So we're not going to go through these today. That's another lecture. So we're really focusing on health measures that can be used in injury research around disability and the sequela that comes from injury. So disability is, just to define that as a framework for how we're moving forward today, is an expression of physical or mental limitation in a social context. And it's the gaps between a person's capabilities and the demands of the environment. As a guiding framework, we're going to use the WHO, the International Classification of Function, Disability, and Health, as a guiding framework. So really our objective today is to describe the state-of-the-art and patient-reported and performance-based health outcomes that are relevant to injury research. So there are many different types of health outcome assessments. There are self-reported measures that we'll be talking about, the PROMIS measures, and I'll go into depth what the PROMIS measures are. We're also going to talk about objective performance-based measures using the NIH Toolbox. We're not really going to talk about descriptive measures that could be characteristics of caregivers or health utilization. We're not going to go into those type of measures, but I think those are more obvious. So they're just thinking about the self-reported measures. There are also global measures of health-related quality of life, and we'll talk about those briefly. And then there are also generic or disease-specific measures. The PROMIS measures are generic measures, and there are also patient-specific measures, which would be when a patient sets their own goals. That would be considered a patient-specific measure. So just moving to the global or health-related quality of life measures. Many of you probably have heard of the short form 36 out of quality metric, and it using item response theory, and we'll talk about what that is. They sort of reduce the measures to also 8. So these are called the short form 8. So these are very typical health-related quality of life measures. It covers several domains. One issue and a problem with these particular measures is they are subject to floor and ceiling effects. The PROMIS measures again are more of the state-of-the-art measures, and we're going to talk in depth about PROMIS, but wanted to just go ahead and show you what a PROMIS adult profile. So the PROMIS 29 version 2, what it does is it covers these eight domains, and the PROMIS 29, you can see, has four items of each domain. So it's a really nice way to get sort of a general sense of the health of an individual. Each one of these are scored differently, so they're not combined. They're kept separate, but you can get a sense of how people are doing, generally measuring these thorough domains. So why is it important to measure functional status? Well, it's prognostic of adverse medical outcomes. It's prognostic of further decline in function and loss of independence. It's an indicator of independence, of the need for formal and informal care, also for the burden of disease, and also a measure of quality of life. So many of you might be familiar with activities of daily living, which cover basic tasks of eating, dressing, bathing, transferring from bed to chair, using the toilet. There's also instrumental activities of daily living, like, managing money, using the telephone, housekeeping, shopping. So the problem with using these as a measure of health is that, if you just look at older adults, not even the general, adult population, only a small percentage, 10 to 15% of adults over 65 or over actually have an ADL limitation. And so it doesn't allow for discrimination across a wide spectrum of functional disability. It would work well in a skilled nursing facility or an assisted living facility, but not in community dwelling older adults. So I'm going to go ahead and jump into just a quick review of some psychometrics here. We're going to talk about, again, the PROMIS measures in a minute, and they were created using item response theory. So I wanted to just give you a brief overview of item response theory, or IRT as it's called. So many of you might be familiar with classical test theory, which essentially has the scale as a unit of analysis. So when someone has a high score, the person's higher on the trait. When they have a low score, they're lower on the trait. The validity is based on the total test. In contrast to item response theory, where the item is the unit of analysis, not the scale. And someone endorses a better rating on a hard item, the person is higher on the trait, and a person endorses a worse rating on easy items, a person's lower on the trait. And the validity is assessed for the entire item bank. And we'll talk about what an item bank is and how you create it. So item response theory is actually a group of models. And we're not going to go into detail in any of these particular models today, but wanted to just kind of let you know what IRT is a group of these different kind of models. I will say that the PROMIS measures were created using this graded response model, which is what you use for ordered responses. So the PROMIS measures are Likert scale, so going to like poor, fair, good, very good, excellent. So they're ordered responses. They're not exactly those categories, but that was just for an example. So just wanted to show you what other models are available there. Okay, so item response theory has two assumptions that have to be met before you analyze data or measures or items using item response theory. So the data has to be unidimensional or only tap into one trait or ability. It also has to have local independence, or the probability of answer any item in a positive direction is unrelated to the probability of answer any other item positively. So the items need to stand alone. And once you have these two assumptions are met, you can go ahead and analyze the data, for example, using a graded response model. And after the analysis, you get something called an item test information function, and also a standard error curve. So here's an example of the standard error curve is the dotted line here, and then this is our test information function. And how you can think about this, if you think, and then theta would be the construct we're measuring. And so the way you can think about this is if you think about this as a standard normal curve, and if you think about this 0 as being the mean, and this 1 to 2 being standard deviations, you can see that. So you out of IRT, you get these curves for the whole all the items you did, either the item bank or the scale you're using, and we'll talk about how you can use short forms. So you get these out of the item response theory, and what you can do is you can look at this and tell that this particular scale is doing a good job measuring out to about 2 standard deviations above the mean, and almost 3 standard deviations below the mean. And that's helpful if, for instance, your theta, let's say, is physical functioning, and you want to give this to a population that is is not particularly good. They have issues or more disability with physical functioning. So you'd want to make sure that it goes below the mean. And so you'd want to pick a scale that covers the lower range, versus if you were measuring, athletes, you'd want to pick a scale that goes, higher above the mean and measures 3 to 4 standard deviations, probably more like 3. So it's a helpful way to look at scales. Okay, the other thing I wanted to talk about are computer adaptive testing, because item response theory allows you to do computer adaptive testing. And so what is, and people call computer adaptive testing CAT. So what does a CAT do? It reduces the amount of time required to complete assessments. It also, what it does is it gives subsequent, when someone responds to an item, it gives subsequent items for administration that are chosen accordingly based on how that person responded. So a CAT employs an algorithm that selects items directly tailored to the person, and then it uses this algorithm and shortens or lengthens the test to achieve either desired precision or a pre-assigned item stopping rule. So you could decide that you want a CAT that only has 10 items in it. So people would be given items until they reach that stopping rule. So if someone's given, usually someone can be given a medium item if they endorse that positively, then they would be giving harder or higher items. If they endorse that negatively, they might be giving lower items. And so people could get different items, but they're scored on the same metric. So IRT methods are used to create these item banks, and you need an item bank to collect to do a CAT and create the algorithm. So the item banks would contain many items covering the length of the construct. And so then those items are pulled for the CAT, and people are given them. And then based on their answers, then people are given other easier or harder items from the item bank. Okay, so wanted to just talk about the process to create an item bank, and we're going to go through each of these individually. So first, you want to identify the items. And so what PROMIS did is it began by depositing items into an item library from well-established instruments. So they took legacy measures that people already use in particular domains and deposited them into an item library. So they had thousands of items that were relevant to particular domains that PROMIS wanted to measure. And they documented, what kind of stems, what kind of response options, what kind of time frame that each item had. So this was identifying the items. Once they identified them, then they wanted to classify, select, create, and revise the items. And they did this by putting the items in bins based on content. and then they took out items that were redundant or inferior to all alternative items. So they winnowed down the items that were in the particular bins. So the items that were winnowed down were then reviewed and revised to be consistent in the style, to meet the 6th grade reading level, and to be consistent in a set of response options and timeframes. So once they did this, then they gave the items to focus groups, and they wanted to confirm the definitions and identity and common language related to the domain, and to identify important gaps. They also wanted to identify, so using the focus groups and cognitive interviews, they wanted to identify any problematic items that people weren't understanding correctly, and they wanted to clarify these. And they used different qualitative techniques to have people complete a paper and pencil version of the measure, followed by an interview asking probes for the basis of the response. Again, to just make sure that the items were answering what they wanted. So wanted to just give an example of how one item bank was created. So in PROMIS, they use the physical function as a latent trait. So the first thing you have to do is define the item. So if you define physical function as the ability to carry out various activities that require physical capability, ranging from self-care to more vigorous activities that require increasing degrees of mobility, strength, or endurance. So first you're defining the construct. And this is an example of legacy measures that were put into the item pool. So these are 2 measures that are used frequently in arthritis. So these are measuring physical function. So these are the items from these scales would have gone into the item pool. The physical functioning 10 items from the SF-36 would have gone into the pool. So even sort of more health-related quality of life, if they're measuring physical function, would have gone into the pool. And so they started with almost 2,000 items. And then after they did the binning and winnowing down, they then reviewed the items, as we talked about, with focus groups, and then they had 168 items that they tested out in the field. And based on analysis from those almost 20,000 responses, they ended up with a 125 item bank that resulted from the IRT analysis. So this is the final item bank that would cover the wide range of the construct. So this is a diagram that shows you, again, these are the standard error curves. And you can see that this is the PROMIS measure that has 20 items. And you can see it does a pretty good job, about a half standard deviation above. And it does a better job in the lower range. And then if you shorten it to 10 items, you can see it pretty much does about the same, maybe not as low down, but it still does pretty good shortening. So you can see that item response theory is a nice way to compare different measures and to select the one that would be good for your particular construct that you're measuring. Okay, so finally, I want to introduce what PROMIS is. So PROMIS is a patient-reported outcomes measurement information system, and it is used to evaluate and monitor physical, mental, and social health. It's relevant across all conditions, so it's not disease-specific, and they used IRT to develop it. And HealthMeasures doesn't only support PROMIS, it also supports NeuroQual, which measures for neurology, people with neurology disorders, the NIH Toolbox, which we'll talk about, that works toward performance measures, the AskMe, which is for sickle cell, and it scores all the measures on a T metric, on one metric, and it's translated to many different items. I'm going to skip this slide. We've already talked about it. So want to talk about the different types of PROMIS measures. So you can have a short form, which is actually a static measure, or you can have the CAT, as we discussed, which is taking an item bank and the items are pulled using the stopping rules with 4 to 12 items. And then you can have the profiles, which we discussed, like the adult profiles that were they're static and doing 4 items of each domain. So PROMIS was created using these domains from the WHO of physical, mental, and social health. And you can see and you can see the domains here that were measured under each of the broader categories. So you can see it measures every, a pretty wide range from GI symptoms. It covers with pain. It covers a lot of subdomains of pain. So it's covering intensity, interference, behavior, quality. And so you can see it also under mental health covers self-efficacy for managing chronic conditions, not just anxiety and depression. So it covers a pretty wide range of constructs. And it also covers the same for pediatric and proxy measures. And it uses item response theory. We've already talked about this, how it has a Likert scale. And so it allows you, if someone selects not at all, if you're measuring fatigue, they're going to end up being energetic. And if you're with fatigue, because you're measuring this unobservable domain of fatigue, if they endorse very much, you know that they are severe. So how do you get the PROMIS measures? Well, you can go to the HealthMeasures website and download these for free. And they have hundreds of measures available. You can search them there, and you can search them by preferred language. And they also have a lot of guides that you can also use for specific patient populations. So for example, you can, they have sort of batteries for, what you would do for cancer patients, what you might do for orthopedic patients, what you might do for GI patients. So they have a battery of measures that they suggest for these different disorders. So how do you administer and collect these PROMIS measures? So you can use paper. So if you're doing the short forms, that means they're the static measures. You can do that with pen or paper. And so that no technology is needed. If you want to do the CATs, you have to use a computer. And if the CATs are already in several systems. So REDCap is a data collection system out of Vanderbilt. Epic is a medical record company that many hospital systems use in the States that has the capability to do the CATs. And then you have the assessment center, which is out of PROMIS, and you can coordinate with them and use their assessment center to do the CATs. And you also can use a PROMIS iPad app that you could use to collect the static measures and the CATs. And there is a yearly fee to PROMIS of $4.99 to use the measures. But the app is available in the iTunes store. So how do you score and interpret the PROMIS measures? So there is probably the easiest way is you can send PROMIS your raw data. It needs to be set up so it's not giving away any identifiers. on the patients, but you know, they guide you for that. And you upload the raw responses, and then you receive them back scored. It's probably the most accurate one because they're using the most up-to-date scoring algorithms. You also can get a score if you're using any of the systems that already have the cat in it, or just the measures in it. They will score it automatically. So again, REDCap, EPIC, and the assessment center, which is something that is out of PROMIS and you know, can be used by anyone if you don't have REDCap and EPIC, and it will automatically score the measures for you. You also can score the measures by hand. The PROMIS gives you manuals to do this, and it is a bit tedious. I've done this. It is tedious. You have to do a lot of coding in SAS or Stata to get the algorithms to score, but they give you detailed instructions in the scoring manual. So it is something that can be done by hand. And so how does PROMIS score the measures? Well, they put everything on a T-score metric where 50 is the mean for a relevant reference population, and 10 is the standard deviation of that population. And the meaning of the score is defined by how it compares to the scores of others in a reference population. And we'll talk about what the scores mean. So here's an example. If you look, this line here is symptoms, and this line here is function. So you can see that if someone has a symptom like pain behavior, or if they have a symptom like fatigue, that the higher they score on the T-score means that the worse they are on the construct. If they have a function, so for example, their ability, like physical function here, if their function is higher, then there you can see they're in this green area, so they're doing better on the construct. So I'm saying this because you have to pay attention on, you know, how you score the measure based on which direction it's going, but the PROMIS gives you guidelines for that. This is how they're scored for the pediatric measures. They have a set way of scoring those for the pediatric and proxy measures. These are how the global measures are scored. So you can see similar, but they're going one direction. And so these are some examples that if you go low with these measures, that you get a worse score. If you go high, it's better. So they're just giving you an example of how you need to pay attention to how the score is measured. Here's an example that high is worse. Okay, so these are like nicotine dependence. If you're scoring high on that, it's worse. So again, you have to pay attention on how the different measures are scored. PROMIS also allows you to compare or link the measures. You can, so maybe you want to compare the measures across cohort studies. There's something called Rosetta Stone that was created via an NIH grant. And so what it allows you to do is take scores on legacy measures. So here's our global measure, short form 36, and it allows you to take these legacy measures and it converts it into a T-score so you can get it on the same metric, and then if you have a data set or cohort where if you've used the PROMIS measures, you can compare them on the same metric. So how are people using PROMIS? Well, here's one example, I think a really good one from the University of Rochester in New York. So they administered the PROMIS CATs to every orthopedic patient since 2015, and they had the results that are viewed immediately in EPIC, and they already have 1 million evaluations as of April 2017. So you can join if you're interested in learning more, keeping up with what's going on with PROMIS and using these measures. I'd suggest joining their Listserv. So you can join that here. I can make these slides available. And and also again, PROMIS was created with an NIH grant. So want to give them credit for this. Okay, so want to talk about the NIH Toolbox briefly. So what is the Toolbox? Well, essentially it's performance-based measures, except for emotion, which is still patient reported, but for cognition, sensory, and motor, they're patient performance-based measures, and they cover really a wide range of age from 3 to 85. And so they're supported by health measures, as I said. So the same as PROMIS, they're kind of under the umbrella of health measures. They cover, again, the domains of cognition, sensation, and motor function are collected versus performance-based, and the motion is self-report. So here's an example of the different domains and what subdomains are collected. So we have under cognition, you can see we have episodic memory, we have processing speed. I won't read them all here, but under sensation, we have olfaction and taste, visual acuity, hearing. Under motor, we have gait speed, standing balance, grip strength. Under emotion, we have stress and self-efficacy, social relationships. So you can see that it's a nice range of measures that can be again given from 3 to 85 years of age. It's also collected with item response theory, so you can see why I reviewed that at the beginning. And again, if you want to obtain or administer the NIH Toolbox measures, there is a iPad app that you can use to administer the NIH Toolbox measures. There is a fee for that based on up to 10 iPads, and you can use the paper forms. You can already download the emotional patient reported outcomes on the HealthMeasures net. And again, there's really a lot of online training that HealthMeasures has provided. So you can go online and they have videos to train how to do these measures, and those are free. So again, if you go to healthmeasures.net and go to NIH Toolbox, you'd be able to see that these different webinars on the trainings. The NIH Toolbox also has training workshops that you can tap into. That they might be held virtually now as well. So it's something to look at on training on how to use this. And then they have a thorough administration manuals. So again, how do you get this? I've already talked about how you can download the emotion measures for free. Then they're also like the PROMIS measures, they also give you batteries to give for specific measures. And then how are people using the NIH Toolbox? So I'll just highlight one example of a pharmaceutical company they had a 25 country trial, and they gave the cognition measures to assess cognition change and an intervention for individuals with Fragile X syndrome. So that's just one example of how they're used. And again, here's just some information on joining the Listserv, and also just recognition of the NIH grants that was used to create the NIH Toolbox. So I'm going to stop here so we have some time for questions.
I actually had a question.
Sure.
When you're talking about the winnowing down part for the PROMIS measures, how really did they do that? Was it just the people doing it decided, oh, well, this one looks better than that one? Because, you know, often when you're using legacy measures, they're measuring almost like a depression measure. A lot of them ask the questions sort of the same way or slightly different. But in a lot of legacy measures, they have different response categories. And the PROMIS measures all sort of are on this Likert type scale, but a lot of the legacy measures aren't.
Right.
I was just wondering about, I've always wondered about that process. So
yeah. So I think when they're put in bins, the items, you know, they're just putting in bins like, oh, it's measuring this subdomain. It's, you know, it's looking at stair climbing, or, you know, so they're all put in the same bins. And then when they win them out, they, you know, they don't want 4 measures of stair climbing, so they would select what they think was the best measure and get rid of the other ones. And the way they did that is they had a network of experts looking at the items and help in doing that process, and they have publications that go through that. And so and also if so it was really based on mostly on redundancy, and if they thought one item was inferior to the other. And then after they put them and winnowed them down, then they stepped back and looked at similar time frames and the health literacy level of each item. So I don't know if that answers your question. So they might have taken a legacy measure item and changed the response time frame. So I don't think if one legacy measure had a certain time frame and another one had another time frame, they would have changed that time frame to equal all the others. So the legacy measures aren't necessarily exact in the item banks. They've been sort of standardized.
But if you look across the PROMIS measures, they have different time frames for different scales.
Right.
Like some of them, they don't state a time frame, and some of them it's less, right?
Yeah. So within, like if they're within that particular item bank, they would have similar time frames. If they're giving people, the same items, they would be similar within that particular item bank. It might vary based on what the construct they're measuring.
Right. Yeah, I just know when we've looked at the PROMIS measures, and again, it's mostly in the social mental health stuff, that you have to tell people to be careful to read the instruction, like what's the time frame, because they can jump around if you start combining a lot of measures, and that the investigator has to think about what they're interested in. Right. Also, the other, I'm sorry to monopolize, but I don't see anybody else putting something in. wasn't PROMIS done for patient-reported outcomes of something? I mean, wasn't that the idea behind it?
Patient-reported outcomes.
Okay, yeah, isn't patient-reported outcomes that this is what PROMIS
Measurement,
stands for?
yeah. Patient-reported outcomes measurement information system.
Mhm.
But it can, are you saying it can only be used on patients?
No, I was just, no, my question was, wasn't that the original thing? I mean, so in terms of epidemiological studies, people are using them, but do they, I don't know, do they work as,
I see whether they work in community-based participants. Yeah, and I think for the testing, they also got community-based. Some of them were clinical-based, but some were not. And so you can use them for community-based measures. If you do, like, if you're interested in individual changes, you want to use the measure with more items. And if you're interested more in more average in your population, then you can use the shorter 4-item ones. But you might if you looking for individual change, it's better to use the longer scales.
right, okay. I mean, in terms of, I mean, I guess what I was looking at them from, I mean, so for example, for depression, the depressive items all have to do with depressed mood, which is different than depressive illness.
Right.
So you're just, right? Because illness isn't distributed. It's just, it's different. So so basically what you're saying is compared to other people in the population, this is where these people rank.
Right, exactly. And, so maybe with depression, I mean, these are involved, evolving, and it might be in the future that someone expands to 3 domains of depression, like they did with pain. So they must have gotten real experts in pain because they have 5 sort of subdomains of pain, but maybe they had less in mental health, and so they ended up with a more general one and not more subdomains. So they may have that coming out as they get feedback about that. The measures, they'll have new measures that are coming out, less so now because I think it is still funding, but I don't know if they're in the creation phase anymore. But I wouldn't be surprised if in the future that they had others coming out. So you do just, I mean, the first thing is, like, what is the construct you want to measure? And it might be that you're only using that to get depressive mood, and then you're using another legacy measure to get what else you want. So when I use the PROMIS measures, it's always a mix of some legacy measures, and then the PROMIS measures. Like I wouldn't collect the HAC necessarily, and which is physical functioning, and the physical functioning one. But I might, if I'm looking at low back pain, I might do the physical functioning one for general low back pain, but I might go to the Rowland or Oswestry, which are very specific, disease-specific measures, just because people would expect that. And, there's a lot of scoring in use in many different populations. So sometimes you want to go ahead and use a legacy measure. Or in your case, it might be that just the construct isn't covered well enough, and you want to, cover the subdomains.
But basically, if you want to look at individual stuff, the recommendation is to use the longer. You know how they have the short form and the short, and then sort of to use the longer one, like if you were doing Okay.
Yeah, and you can still use the short form, but you'd probably want to use the one with more items. So instead of the short
Right.
form 4, you might use the short
the
form
8.
12 or something.
Yeah, okay.
Yeah, or 8 or the, more.
Okay. Well, I think we're at our time. Does anybody have any questions? I don't see any questions in the chat. Well, I'd really like to, this is great. I mean, are your slides available? I mean, I
Sure,
thought it was a great
I'm happy to
explanation.
share them. Yeah.
It's a great explanation of IRT, which I've always been a little suspicious of, but but it was really very interesting. You explained it. Now I feel like I really understand it. So that was terrific. So
Okay,
thank
good.
you very much. And I think we're at the end.
And then Prudence, how do I get the slides to you?
Oh, well, you're at Columbia, so I'll send you an email.
Okay,
But
great.
I'm not
So
sure how to get it for the conference.
Sure.
But
So my uni is TJM 2141. TJ Tom Jack Mary 2141.
Okay.
Okay.
Thank you.
Okay.
Thank you
Well,
very much.
Thank you.
Okay.
And so nice to be here with everyone this morning. Enjoy the rest of the day at the conference.
Thank you.